Hello and good morning, students. How are you today? I hope you're all fine and well. Today we are going to continue with our cardio phys lectures. So we're going to get into the action potential, okay? Action potential. So now, this is a way that I like to understand action potential, all right? You're going to see this graph first. Let me do it like this. You're going to see this graph, like so. Then you're going to see this one as well. So now, immediately I notice a difference in the shape, correct? Well, first of all, which one comes from the atrium, right? SA node, AV node, or pacemaker, aka the atrium, right? Well, this one. Why? Because it looks like an A. See that? A for atrium. Therefore, by default, which one comes from the ventricle? Well, this one comes from the ventricle, but how else can I imagine that? Well, with enough imagination, kind of, sort of. See that? Looks like the word ventricle. See that? Or at least like a V, kind of, sort of, right? All right, good. So that's the first thing. Next, we have what's known as phase 0 and phase 3 in both, phase 0 and phase 3. And we also have a phase 2 in the ventricle. And we have phase 1 and phase 4, but we're not going to get into that today. So with phase 0, okay, what I want you to always remember is that it represents depolarization. Depolarization. Okay, every time you see the phase 0, you say depolarization. Every time you see the word depolarization, you think phase 0. They go hand in hand. Now, really quick, to depolarize, what does that mean? To become more positive or more negative? To become more positive, okay? Meaning we go from the base and we're moving up. We're becoming more, we're becoming more positive, okay? That's depolarization. Well, then what about phase 3? Well, phase 3 is known as repolarization, meaning we were once positive and now we become negative. You see that? Or we're getting to become negative. So that's known as repolarization. Same thing here. Repolarization for phase 3. Every time you see repolarization, you think phase 3. Every time you see phase 3, you must think repolarization. So now, in the atrium, which electrolyte do we use to depolarize? Well, I want you to remember that we use calcium. Moving in or out? Moving into the cell. Calcium moving into the cell, okay? That would lead to depolarization of the atrium versus the ventricle. How do I depolarize the ventricle? Well, not with calcium. We're going to use sodium, moving in or out. Again, moving into the cell because calcium has 2 positive charges and sodium also has positive charges. And again, we're trying to become more positive, so they must enter in order for the cell to become more positive. What about phase 3? Well, in phase 3, we are talking about potassium exiting in both ventricle and atrium. Okay, so what I want you to remember is that if I were to ever ask, uh, how do I depolarize any cell? The elbow, your big toe, the little toe, doesn't matter. It would be sodium because by default, we depolarize by sodium. 95% of all cells will depolarize with sodium, okay? Versus calcium, which is predominantly in the SA node or atrium, and there's a little bit in the thalamus as well, okay? So good. That means that if a patient has a spontaneous depolarization, such as maybe a seizure in the brain, right, a seizure, then maybe to treat, you might want to block sodium, right? Makes sense? Or maybe pain. Well, to feel pain, right? Well, that's you need to depolarize in order to feel that. So again, sodium. So then, how do I block pain? I block sodium, right? Lidocaine. All right. So what else? Tachyarrhythmia could be sodium, right? Like VFib, VTAC, sodium. So what I do, I give them, again, lidocaine, sodium channel blockers. You see? All right. Versus atrial issues. See, if it's in the atria, like an atrial tachycardia, AFib, a flood or something like that, then I would more than likely give them a calcium channel blocker. You see? All right. And then when do I give potassium channel blockers? Usually when the arrhythmia is so severe that a sodium or calcium channel blocker would not work. All right, so basically when ish hits the fan, I like to say. Now, what about phase 2 in the ventricle? Well, here this is also calcium, but you see this calcium is not used for depolarization. He's used for contraction because, I mean, think about it. What's the point of depolarizing in the first place? Well, I want to contract, right? I depolarize to get a contraction, and then I repolarize. First you shoot, then you contract, or I'm sorry, first you depolarize, then you contract, and then you restart the whole process. You see, you repolarize, okay? So wonderful. We depolarize with sodium. Calcium comes in to contract to contract the muscle, and then potassium will exit to repolarize the cell to start the whole process all over again. Compared to the atrium, calcium comes in and potassium leaves. Now there is also contraction, but phase two is so quick. It's not noticed in the atrium. So therefore, we don't even mention that. Now there is something else I would like to discuss in regards to the ventricular action potential. Now again, we have phase 0, phase 2, and phase 3. Okay. So with phase 0 depolarization, let's say we have I don't know 100 sodium channels. Okay, only 100 sodium channels. That's all we have. Okay, so this sodium is going to enter all 100 channels. All right, great. So what happens is that all these channels are now saturated. If the channels are saturated, then can any more sodium enter and lead to further depolarization? Well, no, right? Because the channels are saturated. Well, for how long are they saturated? So they are saturated roughly from right around here to just about here. And this area is known as your absolute refractory period. Then we have from the end of the absolute refractory period to basically the end of repolarization, that would be known as your effective refractory or relative refractory period. So, all right, great. What does that mean, Dr. Lopez? Right? When our channels are saturated, I won't have the ability to depolarize any further. And the question was for how long? Well, as I mentioned here, for about this long. This means absolute refractory period, meaning absolutely nothing can occur because my sodium channels are fully saturated. So absolutely nothing else can happen while these channels are saturated. However, once we get into the effective refractory period, we are now desaturating some channels, not all 100, but maybe 10, 15, 20, right? So if that's the case, and let's just say I just so happen to have a sodium hanging around over here, if he makes it to this area, could it potentially lead to depolarization? Yes, it could potentially lead to a depolarization. You see? However, uh, the creator was nice in that he made the ERP last such a short time that it wouldn't even matter if we had sodium there. It doesn't last long enough for sodium to do what it would do. However, what if I were to prolong the ERP? Well, how would I do that? As we can see here, the ERP, as I mentioned, is very related to or highly associated with phase 3. And as we said, phase 3 is associated with potassium. So what will happen if I give if I give a patient a potassium channel blocker? Well, you will have something like so. Have something like this, and then you'll see this. So can you see how now the effective refractory period has prolonged? What that means is that my unsaturated or desaturated channels are now exposed much longer, allowing for an ectopic sodium to or an ectopic beat to cause arrhythmia. Okay, so it could be due to sodium channel blockers that can potentially prolong phase 3, like type 1, 1A, right? It could be also due to potassium channel blockers as well. And there's also a couple of other unique diseases that are they just so happen to have prolongation of QT interval. All right. So here with torsades de pointe, what I really want you to know is that this is just another fancy way of saying ventricular arrhythmia. Okay, I want you to know that it has this unique appearance because many times they'll give you the appearance. You just have to really know what's happening. Now the question is, what can lead to it? Again, like I mentioned, prolongation of the QT interval. Now again, I said when I prolong the QT interval, it can lead to arrhythmias. Any type of arrhythmia, they just happen to call it torsade de pointe. That's fine. That's fine. Call it whatever you like. Okay, the point is it's going to lead to arrhythmia. Many times, what I do want you to remember is uniquely it could be due to a decrease in magnesium. So then, how do I treat? Give them magnesium. You see, who gets magnesium deficient? Alcoholics are classically alcoholics. Okay, so please be on the lookout. And here we have a wonderful little mnemonic for other things that prolong QT interval. So again, talking about that, we have these two diseases, Romano-Ward and Jervell-Lang-Nielsen. Jervell-Lang-Nielsen has the deafness. How do I remember that one? Simple. If I were to say, hey, what's your name? Oh, they call me Romano-Ward. Nice to meet you. I'm Dr. Lopez. That's easy to understand. Hey, what's your name? Oh, they call me Jervell-Lang-Nielsen. Excuse me? Yeah, they call me Jervell-Lang and Nielsen. Huh? Say that again? I'm not understanding you. So what does that mean? Jervell-Lang-Nielsen, the one that's hard to pronounce and hard to understand, is the one that has the deafness. Okay. Brigada syndrome is just a right bundle branch block seen in Asian males. That's all I have to say in regards to that. Okay. Right bundle branch block. Remember, in regards to splitting, if I have a right bundle branch block, it can cause widening of the splitting. Wolff Parkinson White. What I want you to think about Wolff Parkinson White is young patient. Usually it's a young patient, okay? And when I say young, I'm talking about, 19, 20, 20, 19, 20-year-old young adult, okay? So a young adult with Wolff Parkinson White with palpitations that come and go with or without syncope, okay? They're going to say it's due to an accessory conduction pathway. You say, well, what does that mean? Well, if I were to draw my heart here, like so, I'm sure you remember that we have our SA node up here in the right atrium. There's the left atrium, right ventricle, left ventricle. So I'm sure you remember we have our SA node up here. We have our AV node right here. The electrical impulse goes from the SA node to the AV node. It goes around via the bundle of Kent, and it comes back and it meets, right? Bundle of Kent towards the left atrium. And then from there, it goes and it gets sent through the bundle of His down to the Purkinje fibers and around, right? Around the ventricle. This is normal. So then what's the issue with Wolff Parkinson White? Well, in Wolff Parkinson White, you have an ectopic site, let's say over here. And what he's doing is he is also depolarizing the ventricles, but completely bypassing the AV node. So can you see how this is a problem? It's going to depolarize the ventricles as the AV node is trying to depolarize the ventricles. So all in all, it's a ventricular arrhythmia. How would I treat a ventricular arrhythmia? Probably give them a sodium channel blocker because I'm trying to block sodium because we are blocking the ventricle. Also be on the lookout for the delta wave. Also be on the lookout for the delta wave. Okay, so with AFib versus AFlutter, make sure you know that with AFib, you're going to have non-discernible, no P waves. Okay, you cannot see any P waves, and you're going to have that irregular heart rate with the R to R intervals, which are abnormal. Okay, because this is a atrial issue, an atrial arrhythmia, you would want to give more likely a calcium channel blocker, not a sodium channel blocker. You see that? Now, AFib can also lead to clot formation, thrombi formation in the left atrium, which could eventually embolize and lead to a stroke. So you want to make sure you put them also on warfarin. Okay, it's very important you put them on warfarin as well. All right. Now, what if you can't give a calcium channel blocker, right? What if you just, I don't know, we ran out of calcium channel blockers? Well, what do we do now? Remember that we also have our beta 1 receptor that's found in the SA node. So maybe I could give them a beta blocker. That'll also help, a beta 1 specific blocker. Okay, remember the mnemonic is amoeba, beta 1 specific. AFlutter is very similar to AFib, only that you do see the P waves. I can see them, right? They are discernible. There is no the R to R intervals are also normal. How would I treat? The exact same way I would for AFib. Okay, same exact thing. Also, ablation would help. Remember, ablation is when you're literally zapping the AV node. Okay, and then VFib. With VFib, you want a defib. With VFib, you want a defib. Okay, but because it is a ventricular arrhythmia, you also would want to give possibly a sodium channel blocker, potassium channel blockers as well.